Standard theory for dental care. Conduction anesthesia for mandibular nerve. Conduction anesthesia for mandibular nerve. Contents. Introduction. 1. Needles used for mandibular foramen conduction anesthesia. 2. Reasons for using 30G needles. 1. High safety. 2. The needle length is suitable for mandibular foramen conduction anesthesia. 3. Minimal pain during insertion. 4. Reduces the number of needle types that need to be stocked in the outpatient clinic. 3. Surgeon's position. 4. Insertion technique. 5. Verification of anesthetic effect. 6. Prevention of needle stick injuries. References. Introduction. It is said that few dentists perform mandibular foramen conduction anesthesia. Although mandibular foramen conduction anesthesia is a standard dental procedure, there is a reason why it has not become widespread. That reason is that the method taught at many dental schools is too dangerous for private practice dentists to perform. I will explain the correct method for mandibular foramen conduction anesthesia that ensures safe and reliable anesthesia. 1. Needles used for mandibular foramen conduction anesthesia. Dental cartridge syringe and 30G 0.30 by 25 mm needle. 2. Reasons for using a 30G needle. 1. It is very safe. Because the needle is thin, it does not damage blood vessels or nerves. When it comes to injecting medication into a blood vessel, the thin needle prevents rapid injection, thereby helping to avoid damage to other organs. In addition, 2% xylocaine is used as an intravenous medication for ventricular arrhythmias. Therefore, there is no need to be overly concerned about injecting the medication into a blood vessel. 2. The needle length is suitable for mandibular foramen block anesthesia. The needle length is suitable for mandibular foramen block anesthesia. According to Dr. Camijo's oral anatomy, the average distance from the insertion point to the mandibular foramen is 15 mm. Therefore, the needle is typically inserted to a depth of about 2/3 of this distance. Even in patients who are overweight, this ensures the needle reaches the mandibular foramen sufficiently. 3. Minimal pain during insertion. Because the needle is thin, anesthesia can be administered with virtually no pain. Therefore, it is well suited as the first local anesthetic used for children. Regarding mandibular foramen conduction anesthesia in children, Dr. Kasahara of Matsumoto Dental University reported on this in 1980 in the Journal of Pediatric Dentistry under the title Mandibular Nerve Block in Children. That paper outlines the detailed procedure. Please refer to it for guidance. The results of that study are as follows: 380 pediatric patients, no cases of ineffective anesthesia, 4 cases, 1.1% requiring a supplemental injection. 4. It reduces the number of different types of needles that need to be kept on hand in the outpatient clinic. Since this needle can also be used for standard infiltration anesthesia, the outpatient clinic can standardize its supply of infiltration needles to this single type. As a result, this eliminates the hassle of selecting the right equipment. 3. Surgeon's position. Have the patient assume the supine position. Conduction anesthesia via the left mandibular foramen. As shown in the upper right photo, the surgeon positions themselves behind and to the right of the patient. Conduction anesthesia via the right mandibular foramen. As shown in the lower right photo, the surgeon positions themselves to the left of the patient. In either case, use the left thumb as a guide for insertion. 4. Insertion technique. Place the pad of your left thumb on the distal aspect of the last molar, in the depression anterior to the mandibular ramus between the anterior margin of the mandibular ramus and the medial oblique line, and place your middle finger on the dorsal surface of the mandibular ramus to stabilize the mandible. The insertion point is the mucosa 2 mm beyond the tip of your thumb. The direction of insertion is from the insertion point toward the midpoint between the thumb and middle finger. Insert the needle slowly for about 15 mm, parallel to the occlusal plane, starting from the position of the first premolar on the opposite side. Once the needle contacts the bone, slowly inject 1 cubic centimeter of anesthetic solution. If the needle tip contacts the bone along the internal oblique line during insertion, switch to the 3-step method. 5. Verification of anesthetic effect. I ask the patient, "Is your tongue numb?" If the treatment is effective, the patient replies, "Half of my tongue is numb." If there is no visible effect, wait a few minutes and check again. If there is still no effect, administer additional anesthesia. By practicing with a skull model, the effectiveness of mandibular foramen block anesthesia becomes even more reliable. 6. Prevention of needle stick injuries. Needle stick injuries are injuries sustained by healthcare workers during their duties when they come into contact with instruments contaminated with a patient's blood. In dentistry, as shown in the photo on the upper right, these injuries can occur when using both hands to replace the cap on a used syringe needle. The 30G 0.30 by 25 mm syringe needle introduced here is longer than a standard local anesthetic needle, which increases the risk of needle stick injuries. Therefore, we recommend using a needle stick injury prevention device. While commercially available products are on the market, the photo at the bottom right shows a device we made ourselves using self-curing resin. As these photos demonstrate, needle stick injuries can be prevented by placing the cap removed from the local anesthetic needle onto the device and then reinserting the used needle into that cap. That concludes this topic. Thank you for your attention.